You know, I don't think we can say a lot about the general trend or prevalence in the public that hasn't been tested. That's one of the reasons we are so committed to making sure that we can do a prevalence study. What we do know is about the nursing homes, and you see it all over the country, you know, congregate living situations, whether they be in nursing homes, in residential treatment centers, in homeless shelters, as we just learned in prisons, are higher risk situations. We have been working tirelessly. We have the CDC on site helping us as well in working on the best protocols for nursing homes at the local level. Our local health departments and our hospitals have made new partnerships to help nursing homes. We have strike teams we have developed at the state level. And we test in nursing homes now. And with increased testing, that's an increased focus for us. We also want to think about the staff. We treat the staff in nursing homes very similarly as we do to the staff in hospitals. So we are not surprised that we see in a higher risk population and in a congregate living situation the spread. Just last night, I was on the phone with my peers in the surrounding states and comparing some of our numbers, including, as you ran in the dispatch today, about the deaths in nursing home using our new data. We were slightly lower than what I was hearing in other states. I think, you know, we're doing everything we can to provide the very best guidance to help nursing homes. But we really can't say a lot about the general population yet until we can get a better idea, better testing, and better prevalence study.
Yeah, Dr. Atkins,
Thank you.
You and I were talking this morning. We would expect, if a shipment comes in this weekend, we would expect to be able to start next week sometime.
Yeah.
More general testing in the population.
Yeah, let me just say for a moment, if I could, we're going to talk more, I believe, tomorrow. I have some slides and things to show about our testing, how we tier it. And one of the things we've done is created, with scarce resources, Randy, guidance for the whole state. And that guidance evolves as we have more testing, we expand out greater. And it has evolved as we've understood the disease, as everything has. And so we're still doing high risk, so nursing homes, hospitals, symptomatic people, staff, and that's layering out. So we're going to talk a lot more about our ideas of testing in nursing homes, and how we do that to maximize the tests we have. And we'll be talking about that more tomorrow. And in addition to that, you know, as we've always said, Governor, we do frontline responders as well, anyone on the front lines. And then we're doing some asymptomatic in these high-risk areas, as you heard in prisons. And we've learned, and in nursing homes, you know, we haven't done our nursing homes the way we've done, you know, a whole prison or a whole nursing home yet. But even in the nursing homes where we've tested quite a bit, the asymptomatic is huge. So the whole point of testing, it's a point in time. So even in the prison, what the doctor was trying to say is, I can test in a prison, and we're seeing up to 80 to 90% asymptomatic. You have to repeat that testing and watch as people go from asymptomatic to symptomatic or not. And so even a one point in time testing doesn't tell you all the information. The reason you'd want to do that, if the prevalence was low, you could cohort people and separate out the at-risk people from the not. But our asymptomatic rates are so high that you really almost have to treat everyone as if they're potentially positive, and do your planning around that, because the spread within congregate settings, and this is across the country, is so great. So we're doing more focused testing, but not that broad.
Yeah, we'll have more tomorrow or Monday on that. I wonder also, though, if you could talk about, because Randy was talking about the general population.
Yeah.
We are going to start fairly soon to go out and sample the general population.
Yes, and that's that's what I spoke of yesterday, Randy, and we'll talk more about it, but those are our prevalence studies. They're studies based on working with the World Health Organization. It's the type of study you saw New York City do recently, where they got some of their first prevalence numbers. And, we have a team of researchers led by a group at OSU, but using faculty across the state. And it will actually go out into our communities. We'll begin, it's called a 30 by 30 prevalence study. You start with a basis of 1,000 tests, and we're going to be doing, hopefully, both the antibody testing serologically. We're also going to be taking blood and doing a type of antibody testing to test the accuracy of the quick assays. As you know, the antibody testing has had various levels of accuracy so far in the data. So we're actually going to use a blood test, which is unique about Ohio. We're going to actually test the accuracy of the antibody tests. And also that type of antibody we're doing that's looking at neutralizing antibodies. It's a lot of geeky science, which I love getting into, but for viewers at home, it's the same thing we're testing in hospitals on people who have recovered and are donating their antibodies for convalescent plasma. So we're going to be doing that study starting Monday. It takes about 2 weeks to do, another week to analyze the data. In addition to some surveys of symptoms, we're also, Randy, measuring other things now. We're looking through emergency room data and our existing surveillance on influenza-like illnesses. We're looking at deaths that are excess deaths. That at this time last year, what was our death rates? What are excess deaths? So there are a number of things we're looking in the future at positivity rates of tests. So there's a lot of data that my peers and I are starting to look at as ways to get deeper and deeper into our understanding of this disease. Thank you.